Good evening, everyone. I'm amazed by how many people have actually made it this evening, although I guess for many of you it's still afternoon. So I do want to start by thanking everyone who's joined us, as well as to thank Cassie and friends for making this possible. Before I go anywhere with this, I do want to acknowledge that because of lived experience, for many people, what I'm going to say is, to a large extent, I think something that you already know. What you guys have lived through gives you an understanding of disease that I can't begin to compete with. But my goal is to hopefully run through some, what are probably pretty basics of juvenile dermatomyositis. I'm going to introduce you to a friend of mine who has given me permission to use her life experience. And then I'm really looking forward to the question part of this. So I'm going to go ahead and get started here. That's possible. Maybe I'm not. There we go. So I do have a couple of disclosures, which you've already heard. So I'm the chair of the JDM committee for CARA, which is a large North America-wide research organization. I'm also on the medical advisory board for another patient group called JDM, but I don't really have any relevant disclosures. My goals for this is to talk a bit about what juvenile dermatomyositis actually is, talk a little bit about tests, because I think that's often a big area of questions that we get, and to talk a little bit about treatment. And then, as was indicated, we're going to have lots of time for questions. So the young lady I'm going to introduce you to briefly is a 10-year-old girl who I actually met probably pretty close to 20 years ago now. She'd been previously well. She had complained of some fatigue for about 3 weeks. Her family had noticed that she had some redness on her face and her hands for the last year, but nobody really thought very much of it. And then everybody sort of realized there was a problem when she was playing goal for her hockey team, and the coaches had to come onto the ice 3 times to help her stand up. And they sort of thought it was because it was warm, and so there was lots of water on the ice, and she had new pads. But in retrospect, she'd actually been getting weaker for the previous month. These are actually some pictures that are actually her. As I do have some permission to show these. And you can see that there's some pretty minimal redness on her hands. It wasn't super exciting. She definitely had some redness on her cheeks, which I don't think the picture really does justice. And then she had some other areas of a little bit of rash here and there. You can see sort of the inside of her elbow crease. This is her MRI, and we're going to come back to her MRI a little bit later, because I'm going to use it as an example of what MRIs look like. But I will tell you right off the bat that this is really abnormal. And this young lady was diagnosed with juvenile dermatomyositis. She was started on what at the time was typical therapy, which was IV steroids to start with, followed by oral steroids, and then methotrexate, and then IVIG, and then cyclosporin. Because unfortunately, she had an extremely difficult course, probably one of the more challenging courses that we've seen. Never severely ill, but it would not be an exaggeration to say that just about every complication of either her illness or her medication that she could have had, she had. And I've listed them here. We don't need to focus on that. But the reality is that she was in hospital for more than 2 months and really had a very, very difficult course. But on the positive side, 3 years later, she was off of all of her medications. She was back to completely normal function. She was back to playing hockey and living her life, and really had no active disease features going on. And it's actually now been 20 years. I haven't seen her for probably 10 years since she graduated out of our clinic. But to the best of my knowledge, she has never had a recurrence, despite the fact that she had really very difficult disease. So I'm going to introduce a couple of concepts here. Probably the easiest one to introduce is, where does this name dermatomyositis come from? And as with many of the various long words we like to use in medicine, it's derived from Greek and Roman. And if you actually know the derivations, you can figure out what you're talking about. But dermatomyositis refers to dermato, which is skin, myo, which is muscle, and itis refers to inflammation. And when we talk about inflammation, we're talking about a process where the immune system has turned on you, and instead of doing the important stuff like fighting infection and looking after you, it's actually attacking parts of your body. And in this illness, it's primarily skin and muscle. The concept I do want to introduce, though, is this concept of juvenile idiopathic inflammatory myopathies. And it turns out that there are actually several separate but overlapping disorders that we like to group under this sort of umbrella of juvenile idiopathic inflammatory myopathy. And so this includes JDM, which is by far the most common, probably 80 or 90%, depending on how you define things. But there are some other problems like something called juvenile polymyositis, which looks mostly like the muscle part of dermato, but not the skin part. There's a more complicated, probably subgroup of polymyositis called immune-mediated necrotizing myopathy, which is actually a relatively recently diagnosed or recognized disorder. Some people who have other connective tissue diseases, so illnesses like lupus, can develop a muscle inflammation, which really looks just like dermatomyositis. And there are a number of other really rare inflammatory myopathies, which quite frankly are so rare that I may go my entire career without ever actually seeing one, but we do sort of keep these in the back of our mind. But in general, when we're talking about these problems in kids, we're really talking about dermatomyositis. So my colleague, Lori Tucker, did speak a little bit about some of the sort of the basics, but these are rare disorders. They affect somewhere between 2 and 4 per million people. So you're not quite 1 in a million, but you're pretty close. They're considered to be autoimmune disorders. So these are problems where the body is specifically attacking parts of itself. Girls are more affected than boys, somewhere between 2 and 2.5 to 1. And we've already talked about these different subtypes, so I won't go over that again. And most of you will recognize the different features that we're talking about. So muscle weakness is the thing that people will sometimes be the most concerned about, although it's sometimes not the first thing they notice. And this is a weakness that affects primarily the proximal muscles. So the muscles of the hip and shoulder girdles, muscles around the spine, and less so the muscles of the hands or the feet, or even the lower arms or lower legs. Sometimes this is manifest as weakness and inability to do things or making it harder to do things. But sometimes it's actually more subtle, and it can be just endurance, or it can be just the things that you normally do are just harder. Now, the other aspect that everybody's familiar with are the various rashes. And I'm going to show you a couple of pictures here. So I'm not going to go over this in detail, but the heliotrope rash is the sort of bluey red rash around the eyes. Gautrins are the scaly red areas over the hands and the elbows and the knees. But there's a whole bunch of other rashes. I'm going to show you just a few pictures. So this is a slightly better picture of what would be very typical Gautrins lesions. So over the knuckles of basically all 3 sets of knuckles of the hand. And you can see that the rash is kind of red. It's raised a little bit if you were able to touch that. And often there's some scaling, although in this case, there's not a lot of that. This is a very nice example of what we would consider to be a heliotrope rash, where you get redness and sometimes a little bit of swelling of the eyelids, particularly the upper eyelid. This young lady has a fair bit more than just the upper eyelid, of course. And you'll notice that your rheumatologist is often kind of looking at your fingers. And what we're looking for are the little teeny tiny blood vessels in the cuticles. And this is actually a really nice picture of this. If this child did not have dermatomyositis, you wouldn't actually expect to be able to see those vessels either at all, or if you could see them, you'd be able to just barely make them out. And in this case, you can see that they're very obvious. And this turns out to be a really useful sign of dermatomyositis, and can actually be quite useful in following dermatomyositis. So these are some pictures that show a little bit more dramatic features. So this is an individual, probably an adult, who has actually really quite prominent Gautrins lesions over the hands. This is a somewhat more subtle picture of the heliotrope rash, which in this case you can see is primarily the upper eyelid. Almost looks like somebody's put on a little bit of very pale makeup. And again, you can see these sort of abnormal blood vessels in the cuticles. Now, the rashes can be much more extensive, and they can be much more impressive. So you can see in the upper left, this is an individual with really extensive redness. And probably if you're able to sort of get closer to that, there'd be some dryness and some scaling of that skin. The upper right, I guess you can probably see my arrow. This upper right is basically upper chest, which is called a V sign rash, given sort of the shape that often sort of occupies a bit of a V. And this is an upper back, which is considered to be a shawl sign rash, which is basically as if somebody was wearing a shawl in that distribution. And this last picture is an individual who really just has basically red, scaly rash, literally over almost his entire body. And so there's a fair bit of variation, but certainly one of the common themes to the rashes in dermatomyositis, they tend to be red, they tend to be somewhat dry and scaly, and sometimes they can be raised, although that's not always the case. Now, it's important to recognize that dermatomyositis is not limited to just the skin and the muscle. And so depending on your circumstances, your physicians may be watching really carefully for lung disease, particularly if you have certain antibodies, which we can talk about a little bit. Some people, particularly very early in their course, will have involvement of the bowel itself, and the blood vessels can be injured, leading to significant bleeding. Arthritis is actually really common. People don't realize that up to 40% of children with dermatomyositis, again, particularly at the beginning, will have arthritis. And extremely rarely, other organs like the heart or the brain or kidneys can be involved, but that's really quite unusual, which is one of the things that distinguishes dermatomyositis from other illnesses like lupus. Now, turning our attention a little bit to investigations. Interestingly, testing in dermatomyositis is often not as helpful as we might like it to be. We do follow muscle enzymes, and it turns out there are actually 5 different muscle enzymes that we can measure. And these are all enzymes that are normally found inside the muscle cells. And so when the muscle cells get injured by the inflammation that's happening in the muscle, they leak out into the bloodstream, and so the levels go up. Individual people may find that one or another of these enzymes are more or less useful for tracking their illness. And unfortunately, for many people, they're actually not very useful for tracking the illness at all because they don't correlate particularly well with how things are going. We always do a bunch of testing to make sure that people don't really have another illness like lupus. And so that's the ANA and the ENA, C3 and C4, which are complement numbers, which are another sort of aspect of the immune system. We look at urine because kidney disease is really common in lupus, but not in dermatomyositis. People will usually get a chest x-ray because we're looking to make sure the lungs look like they're healthy. People will often get an electrocardiogram or an ultrasound of the heart to make sure that the heart is normal. And then there's a couple of tests that you might or might not experience. So the electromyogram involves putting a needle directly into the muscle and then recording the electrical activity. It's something that 25 or 50 years ago would have been very commonly done. And probably in 2021, it's actually become very uncommon. It's invasive and it hurts, and kids aren't crazy about that. And the information that we get from that, we can probably get from other routes. Although there are circumstances where it's difficult to know what's going on, or you need additional information where it's possible that would be used. The other test that you may or may not experience is a muscle biopsy, which involves usually going to the operating room and being asleep, and basically having a small surgery that removes a small amount of muscle so they can be looked at under the microscope. Turns out those last 2 tests have largely been supplanted by the fact that we have MRI. Certainly in North America and other basically Western countries, having an MRI as part of your evaluation, probably part of your follow-up, has become almost universal. When we look at our data from CARA, where we have now more than 200 kids that we're following, the numbers are in the ballpark of 90% of people have an MRI. It has the advantage of being non-invasive. For sort of middle-aged to older kids, it can be done without being asleep, although for the younger kids, it probably needs a sedation. It does have the advantage of being able to look at large areas of muscle all at the same time, rather than a biopsy, which looks at a very, very small area. So this is basically what the MRI that your rheumatologist is looking at looks like. And what you need to know about an MRI is a couple of important things. So the MRI is done by basically putting the body in a strong magnetic field. And it turns out that different tissues, largely based on how much water they contain, basically respond differently to that magnet. And so a lot of what we're looking at in an MRI is differences in water. This particular scan, which is done using a sequence called STIR, which is very important to anybody, basically water ends up being white. And so you can see on the right-hand side, this big solid white thing is this person's bladder, and they still have probably go to the bathroom when they finish their MRI. But you can actually see that in the muscle over here, or over here, or over here, it's very, very white. The normal muscle that's not inflamed is this kind of dark gray stuff. So you can see that there is widespread inflammation in kind of in the upper legs, sort of around the pelvis. These are in the buttocks muscles over here. And so this picture gives us really useful information about the extent of inflammation. Now, the muscle biopsy, as we said, is done much less commonly. In the data we have from Cara, it's probably in the ballpark of a quarter, maybe 30%. It's invasive. It requires surgery. There's always the risk that you biopsy an area that isn't particularly inflamed, and so you don't get to see what you're looking for. But its most important role is that there are other illnesses that can mimic dermatomyositis. So different forms of congenital myopathy or muscular dystrophy, which sometimes, particularly if people don't have a lot of rash, can basically try to fool us. And so most people would argue that if the illness is atypical in some fashion because there's no rash, or because the course is very unusual, or they have features that are not typical, that a biopsy would be necessary. There are other people who are arguing right now that with modern technology, there are biopsy features that can help us predict what the future might hold, what kind of complications we should be looking for, but it's not quite clear how useful that's going to be. So right now, a child who's diagnosed with dermatomyositis tomorrow, there's a pretty good chance they wouldn't actually have a biopsy. Just so that people have a little bit of an idea as to what a muscle biopsy might look like, this is the kind of picture that your rheumatologist and the pathologist at your rheumatology institution is looking at. And there are two most important features that people are going to be looking at. So when the muscle is looked at under the microscope, you basically get these nice little, essentially cut sections of the various cells in the muscle. They get grouped together into these things we call fascicles. And at the edge of the fascicle, you'll notice that the cell here, or the cell here, or the cell here, these are all kind of smaller than these big juicy ones in the middle. And so in dermatomyositis, basically the muscle cells at the edge of the fascicle end up being smaller. And that's a big hint that the child has dermatomyositis. The other thing we look for is all these little dark bluey things. These are all lymphocytes, or basically immune cells. And so we see these clusters of immune cells around little tiny blood vessels. And you'll have to take my word for it, but this little thing right in here is a blood vessel with a bunch of little extra immune cells around it. Turns out that there are usually very few immune cells in muscle. And so when we see even a small number of them, it's usually abnormal. Now, you may or may not have heard about these things called myositis-specific autoantibodies. And this is a relatively new concept in children with dermatomyositis. It's been important in adults for a little bit longer. And these are a number of antibodies that your body is not supposed to be making. They're antibodies that are basically reactive against our cells. And it turns out that there are a number of these that are seen only if you have dermatomyositis. There's a bit of a list that I've sort of thrown up here, which we don't have to go into any particular detail on. But what's important about these antibodies is that they seem to predict different kind of subgroups of people with dermatomyositis. So If you happen to have this one called anti-Jo1, you're more likely to have lung problems. If you have this one called anti-TIF1 gamma, you're more likely to have really quite sometimes difficult skin disease. If you have this one called NXP2 or MJ, because they renamed it just to make everything confusing, you might be more likely to have calcinosis. So people are very excited about these as kind of first steps in the direction of being able to tailor therapy specifically to individuals. Unfortunately, there are some challenges with these. They remain relatively difficult to obtain. You can get them from many different labs, but there are concerns with the reliability of some labs. It's not clear that we know how to influence treatment when we know what the antibody is. We aren't quite to the point of being able to say that a child with this antibody should have this treatment and a child with this other antibody should have this other treatment. And unfortunately, most kids still have basically what we would consider to be a typical myositis-specific antibody, TIF1 gamma, that doesn't really change therapy, at least not yet, although we're looking forward to that time. But we do still think it's important to have these antibodies available. It does potentially increase our sort of awareness of the complications we should be looking for, particularly lung disease. And it might actually identify very special groups that really would change how you would treat them. And that's certainly something that we may want to talk about afterwards. So talking about outcomes, in general, children with dermatomyositis do really quite well. When I finished my training, the conventional wisdom was that treatment went on for a long time. And at that time, it was probably about 2 to 3 years. And most patients would return to normal function once they kind of got through that treatment. The data as time has gone by has suggested, well, you know, yes, kids do pretty well, but maybe it's not quite as rosy as that. We know that some people can have permanent muscle injury. They can experience weakness or contractures. They can have ongoing skin problems. They can develop this thing called calcinosis, which I will show you a couple pictures of in a second. They can develop bowel problems with bleeding, and they can develop lung problems, which can be quite serious. So I do highlight calcinosis because it's probably one of the things that we worry about the most. And so you can see in these pictures that there are basically variations of what calcinosis looks like, but this is basically calcium deposits in the skin. And so you can see in this young man here that there are basically these lumps under the skin, and in this person, they're quite extensive. This person here has more superficial lumps that are actually kind of bursting through the skin a little bit, and so they actually have sores. And this person here, this is an X-ray, and you can see that there is basically stuff that's in the muscle that's almost the exact same density as the bone is. And so sometimes there will be these deeper, basically sheets or plates worth of calcium. And this is just a picture of somebody with significant lung problems, just to remind me of the importance of the lung problems. This part of the lung up here is kind of what it should look like, sort of kind of this kind of dark gray, but you can see there's large areas down here and over here that are just way, way, way too white for what they should look like. And you can appreciate how that might be a little bit hard to breathe if you've actually got a lung that isn't as full of air as you'd like it to be. We know that people with dermatomyositis can certainly continue to have problems for a long time. We looked at our data in Canada, going back actually a long time now, and we're able to identify that about a third of patients who were followed up more than 7 years later had calcinosis. About 40% still said they had rash. About 10% said they were weak. And about 35% were still on medications, even though they were 7 years and sometimes a lot longer than 7 years out. So we know that sort of the assumption that after a year or two, everything's going to be great may not be quite as simple as that. I'm not going to go through the details of these other recent studies, but these are all things that have been done in the last 10 years. Again, all reminding us that we need better treatments for dermatomyositis because people do have ongoing challenges related to this. The last thing I'm going to do in the last sort of minute or so here before we turn this over to some questions is talk a bit about treatment. In 2021, standard treatment still includes steroids right up front in usually a very big dose, often in divided doses, sometimes IV to start and then switching over to pills, sometimes pills only, depending on sort of where you're being seen and how ill you are. Almost everybody gets methotrexate, ideally by needle, although sometimes as a pill. And the goal of the methotrexate is to ensure as much as we can that we are able to taper the steroids as successfully, and we don't end up in a situation where people have flares and their steroids go back up. Some people will get IVIG, which is intravenous gamma globulin, which is a blood product, which turns out to actually be quite successful as a treatment for dermatomyositis. And then steroid weaning for most people is somewhere in the ballpark of a year, although there's still lots of variation as to how people would approach that. Turns out that if that sort of initial standard doesn't do the job in quite the way that it wants to, either because people are slow to respond or they have flares or they're experiencing complications, there's kind of a long list of other medications we might throw in. This would include things like rituximab or cyclosporin, very strong medications like cyclophosphamide. Again, there's a bit of a long list here. And the most exciting and probably newest one would be these medications called JAK inhibitors, which some people may have heard of, which may actually have the potential to be standard of therapy in the relatively near future. We're pretty excited about that stuff. So rituximab is an antibody against B cells. It's actually one of the few treatments that's actually been formally studied in dermatomyositis and does seem to have a role for some patients. And there are these medications, I said, called JAK inhibitors. The official names would be tofacitinib or baricitinib. They're actually currently used in rheumatoid arthritis, so they're actually available in the pharmacy today. They've been approved for juvenile arthritis in the US. And the really interesting thing about these medications is that they actually seem to work in a way that matches our understanding of the physiology of the immune system in dermatomyositis. And so there's a lot of hope that these are going to be useful medications, although again, we don't actually have that evidence yet. There's also a new steroid called vamorolone, which is at least purported to be a steroid that has the same effects on the immune system, but reduced side effects. That's actually being studied in some other illnesses right now, but that may turn out to be something that's useful. Although I have to say that my preference would be that we could get rid of steroids completely. I'm not sure how realistic that's going to turn out to be, but that certainly is one of the areas that might be for a sort of a future thing. So just to summarize, we talked a bit about the clinical presentation of JDM. We talked about investigations and assessment. We talked about some treatment. And now I'm looking forward to hearing lots of questions.